Okay, everyone, I think we might get started. It's been a long but very productive day. I hope you'll agree with me with fantastic presentations that we've heard from all the four sessions, and all the panelists. So this final session is titled A Call to Action. Karen gave a really impassioned plea, I thought, in that last session on research for us all to keep on focus with the tools that we already have to scale up vaccination screening for both cervical and anal cancer with the new knowledge that we have around that, but also to keep an eye on new tools that might still come in. So this afternoon, we have a very distinguished panel of speakers to kind of work through on how we're going to make this happen. We not only have the tools, but we've also had modeling results showing the return on investment in at least in cervical cancer to guide governments to implement cervical cancer vaccination, HPV vaccination and cervical cancer screening programs. But alas, as you've heard, only 55% of countries have actually got a vaccination program. And how long have we had this effective vaccine? More than a decade, isn't it? So here we are this afternoon, and hopefully this can form a catalyst for the way forward. As you know, the HIV world is known for its advocacy, and time to get together with the HPV community, I think, to call for price reductions in both vaccines and testing tools. And so we have, like I said, a very distinguished lineup of panelists that's headed by, first of all, Lady Rosalind Marotta, and we feel very privileged and honored to have her here. We've actually interrupted her holidays, who's currently the chair of the board of the Global Fund, and Lady Ross has lived and worked in Papua New Guinea. You've heard of the fantastic program that they have there. And since the time as First Lady of PNG, she has steadily championed health and HIV programs and gender issues. So, Lady Ross, the floor is yours.
Thank you, Adiba, and good afternoon, everyone. Adiba, it's a privilege to open this first session of the final session. Oh, sorry, not the first, the final session of this pre-meeting. And thank you for the opportunity to share the Global Fund's perspective on an issue of utmost importance to us all, ensuring that we achieve effective, integrated HIV and HPV and related cancer prevention, screening, treatment, and care. As you know, the Global Fund is a key partner in the fight against HIV and AIDS. It's our priority to strengthen the integration of prevention and treatment programs for HPV and related cancers, such as cervical and anal cancer, into HIV and sexual and reproductive health platforms. While our mission is to end AIDS as a public health threat, HPV and related cancers are a huge concern for us. As everyone here knows, HPV is extremely common in women living with HIV. In Asia, for example, up to 34% of women living with HIV are also living with HPV. And what's more, women living with HIV are 6 times more likely than women without HIV to develop cervical cancer. And a cancer diagnosis comes on much faster because of HIV infection. Mortality from HPV-related cancers is also higher among people with HIV. Deaths that are mostly preventable with HPV vaccination, early diagnosis and treatment for precancerous lesions, and access to effective treatment of advanced cancer. As more people living with HIV are receiving life-saving antiretroviral treatment and living longer lives, their health, well-being, and longevity are a priority. Recognizing this, in the Global Fund's new strategy and current allocation period for 2023-25, We're encouraging countries to look for greater integration opportunities. First, our new strategy underlines the importance of primary health care in delivering integrated people-centred services and continues to support the screening and treatment of co-infections and comorbidities, including HPV and related cancers. Health systems built on a strong foundation of primary health care are essential to not only end HIV as a public health threat, but also to achieve universal health coverage. Second, our fight against HIV goes far beyond the disease itself and actively contributes to building resilient and sustainable systems for health. Since 2015, countries that apply for Global Fund grants have been able to include interventions for HPV co-infection and comorbidity with cervical cancer, screen and treat programs for women living with HIV. Countries can use our grants to fight HPV by utilising funding for integrated service delivery for sexual, reproductive and adolescent health and integrated public health surveillance. We have observed a slow but steady increase in attention to HIV, STI and HPV-related cancers in grant applications from the countries where we invest. Thirdly, countries can leverage our investments in existing HIV and sexual and reproductive health and rights platforms that serve women, girls, men and boys at risk of HIV or already affected by it. For example, countries can use existing molecular diagnostics platforms like Gene Expert machines for HPV diagnosis. Integrated lab systems and networks can also support HPV testing. And fourthly, the Global Fund has provided very clear guidance to applicants preparing HIV and joint tuberculosis funding requests for this next allocation, 2023-25. This is designed to help countries identify the most impactful co-infection and comorbidity priorities that will improve health and longevity among people living with HIV and other priority populations, such as screening for cervical cancer and HPV, and referrals to HPV vaccine programs. There are proven results to back this approach. In Zambia, for example, the Global Fund has directly invested over $2 million in the cervical cancer program with technical assistance from UNAIDS. On the back of these investments, national cervical cancer program activities have been integrated into the existing HIV program, with the goal of expanding cervical cancer screening to more than 100,000 women, 28% of whom are living with HIV, in 5 years. The program uses a see and treat approach. Women who are screened positive for precancer lesions are immediately treated during the same visit. The Zambian cervical cancer program, together with the HIV program and bilateral partners, has opened 58 cervical cancer screening clinics in most of its districts, targeting women living with HIV across the country. Other countries are progressively prioritizing similar interventions. In the 2020 to 22 allocation cycle, Global Fund investments in integrated programming like this were about $10 million, still a very small amount, but up from less than $1 million in 2012-2014. In Asia, several countries are actively working to expand their HIV programs to include HPV. In Cambodia, the current Global Fund grant supports activities to increase access to HPV vaccination, cervical cancer screening, and treatment for girls and women living with HIV. But much more needs to be done. The Global Fund is actively encouraging countries to develop comprehensive, inclusive national strategies that integrate HIV care and prevention, hepatitis, STI, and treatment of HPV-related cancers. Strong country leadership is critical to ensure that our investments are sound and ensure value for money, and support strong national programs. We vigorously promote inclusive and credible dialogues around health financing at the national level, pushing for faster reforms and better representation in resource allocation decisions by beneficiaries and health service users. We also do not mobilize resources for HIV alone. We actively seek linkages looking for co-benefits and interconnectedness to HPV, hepatitis, STIs and TB, and chronic disease management. We always advocate that HIV, STIs, hepatitis and HPV be included in the basic health package and integrated into public health surveillance. In practice, this means we can support country-led integrated HPV and HIV response efforts with a partnership model that builds on and aligns with PEPFAR's Go Further partnership with UNAIDS, with UNAIDS investments in innovative screening and treatment to prevent cervical cancer, and with Gavi's support to HPV vaccination. We can also invest in service delivery for HPV vaccination efforts. But this means aligning with partnerships to develop country-level elimination strategies, like the one designed in my other home, Papua New Guinea. Together with UNFPA and the Cancer Council of New South Wales, PNG has defined a roadmap for action to eliminate cervical cancer and save lives, and we're seeing progress in real time. The Kirby Institute, together with Cancer Council New South Wales, VCS Foundation, Family Planning New South Wales, and with funding from the Minderoo Foundation, is currently carrying out a cervical cancer elimination project, the first of its kind, hosted in a medical centre in the Western Pacific region, in the Western Highlands of Papua New Guinea. Unfortunately, Dr. Reaper, who's running this program, was to be here to talk on the panel today, but Air New Guinea kindly threw him off the plane, and he didn't get to Brisbane. But I'm hoping Andrew, who knows quite a lot about this program too, might be able to talk about it. So today we have the necessary tools to eliminate HPV-related cancers among people living with or at risk of HIV. But with limited financial resources and flat budgets, integration and leveraging existing platforms are increasingly important. Inequity, as we know, is a huge obstacle to elimination. Services must be designed with users in mind. And equitable provision starts with a strong health system. We must seize the opportunities available and make sure everyone, everywhere, can access these services. A world free from HPV-related cancers and from HIV infection is possible. So let's get to work together. Thank you.
Thank you so much, Lady Ross, for setting the scene for this final panel. And I'd like to welcome back, as you see, Meg Doherty, Lance, as well as Andrew Vallely to the panel. And also we have two additional speakers, and that's Dr. Lucas de Toca from DFAT, Australia, as well as Jane Costello, who's the CEO of Positive Life New South Wales. So what I'm going to do is throw one question each to our panelists and then open the floor for questions. So Jane, I think I'll start with you, if I may. Now, Jane, we've heard throughout the day of the advances in both cervical cancer screening as well as now increasing work on anal cancer screening as well as vaccination. In your opinion, as someone who's openly living with HIV and leading an HIV community organization, what things do you think need to be done to scale up some of the tools that we already have?
Thank you, Adiba, and thank you everyone for the opportunity to speak from a community perspective regarding this really important topic. And as a woman living with HIV, today's meeting is extremely close to my heart. Globally, HIV-related cancer causes 1/3 of all deaths of people living with HIV, and as a group, we experience a significantly higher burden of HPV-related disease. Cervical cancer is the most common cancer among women and people with a cervix living with HIV, and anal cancer is the 4th most common cancer among people living with HIV. So committing to the elimination of HPV-related cancers requires awareness raising across all of our communities around vaccination, screening, early detection, and treatment. So in 2016, Positive Life New South Wales conducted an Australia-wide survey of 1,660 respondents to assess the awareness of HPV-related cancer in gay and bisexual men. We found 2/3 of HIV negative and half of HIV positive gay and bisexual men significantly underestimated their risk for anal cancer. So 2 years later, we conducted another survey, this time for women and trans and gender diverse people with cervixes, to understand their knowledge of HPV-related cancers. The findings showed that these groups had an increased awareness of cervical cancer, but an even lesser awareness of anal cancer. So clearly, we've still got a long way to go in building the health literacy of our communities around the risk of HPV-related cancers, but also support them in active, informed decision-making, especially for those in more marginalised communities where the topic is completely taboo. So it's a job for all of us, clinicians, peers, community, researchers, and government. And I'd particularly like to acknowledge the support and partnership with Richard Hillman at St Vincent's Hospital in Sydney, and with Andrew Gruelich, Mary Poynton and Jeff Ginn at the Kirby Institute, who've been really supportive of our work around, particularly around anal cancer. I think it's fantastic that the CDC guidelines are about to come out, and we will hopefully follow those in Australia. And since the introduction of the National Cervical Screening Program here in 1991, cervical cancer incidence and mortality rates have halved in Australia. So together with the HPV vaccination program, these have contributed to this reduction. And as we've heard already, the Anchor study demonstrated the benefits of including routine anal screening and early treatment as part of standard of care for people living with HIV. However, the lack of clinicians trained to perform anal screening and high-resolution anoscopy remains a barrier for people to access screening and treatment. But if we are to achieve this, we need significant investment and the allocation of additional resources. And I'm sure I'm not telling anybody anything they don't already know. Anal cancer typically presents late when treatment options are limited. Early detection is associated with greater survival rates, and early diagnosis and screening is critical to avoid people presenting late. The issue is, it's a highly stigmatized condition, and I know that Andrew spoke about stigma and discrimination, and I'd like to sort of just touch on that a little bit more. It's embarrassing or difficult for people to talk about, and for those from more marginalized communities and populations, it's simply not on the radar. And as rare as it is in the general community, that lack of awareness really extends not only throughout the communities of people living with HIV, but also to healthcare professionals and GPs, who are often reluctant to mention or discuss anal cancer with their patients. There is an increasing evidence of the benefits from adding a yearly digital anal rectal examination, or DARE, into routine HIV care. Yet in Australia, around 500 people are diagnosed with anal cancer each year, and 60% of these being women. We need to normalise incorporating a routine DARE as part of a regular sexual health check for all people living with HIV. And we really need to implement self-testing. It's acceptable to women because of cervical self-testing, and I'm really proud to be part of the research that the Kirby Institute is doing in this respect. In terms of an HPV vaccination program, I think we need to talk about a prophylactic HPV vaccination program. So here in Australia, the HPV non-valent vaccination is recommended for women living with HIV up to 45 years. But there is a significant cost to this vaccine. It's around $430, I believe. And that's only covered to those aged up to 26 years. Now, there is an argument that there isn't evidence past 26 years, but I think there is an issue with this, and this is creating a potential gap. Overall, people living with HIV have a low HPV vaccination uptake compared to the general population. There's a strong case around public health equity to improve immunisation coverage in groups at higher risk, to reduce morbidity and mortality from HPV-related cancers. So in the context of Australia's goal to eliminate HPV-related cancers as a public health imperative within the next decade, it's critical that high-risk groups are not left behind by ensuring inclusive, equitable public health strategies. Whenever we talk transparently about these issues, over time they do become more normalised and less stigmatising. Peer work is essential work. It has defined the HIV response in New South Wales and Australia across the world. It's only by including people living with HIV that we're going to make sustainable inroads into eliminating HPV as a public health concern in Australia by 2030. Put simply, to echo the title of this meeting, let's put people first in the prevention, treatment and care of HPV-related cancers for people living with HIV. Thank you.
Fantastic, Jen. Thank you very much for that. I'm now going to ask Andrew Vallely, who's very kindly stepped in for Dr. Paulus Riba, who, as you heard, couldn't get on the flight by Air PNG. Andrew, earlier this morning we heard about the fantastic program that PNG is now doing. I wonder if you could share with us some of the lessons learned from this for really both low and middle and high income countries, because really what is being done in PNG is really quite fantastic, and there are many of us who can learn from those lessons, including how do you optimize. We heard during the break that from Lady Ross that there are quite a lot of gene experts around the country for both TB and COVID-19 testing. So how can we maximize and utilize these already existing facilities, as well as the programs that you're conducting for, as a lesson for other countries around the world?
Well, I think, thanks very much. I think first of all, we've been incredibly fortunate in Papua New Guinea because the key research questions were driven largely by, almost entirely by the PNG Obstetrics and Gynecology Society, who came to us, people like Angela Kelly-Hanko and myself, at the IMR, the PNG Institute of Medical Research, and said, what do we do to take an algorithm forward? What do we need to do to deliver something that is actually going to be of benefit in our setting, that's going to deliver for women in our setting, and is going to do something about a disease that touches every family, every community, and is something that, if you had a meeting like this, every single person would say, this disease has touched our lives. It's such a big issue in Papua New Guinea. And so we spent 12, 13, or nearly 15 years working through different algorithms to find something that was credible enough, that was strong enough. We did the field trials, and then we were very fortunate that within PNG, we were able to translate our research findings into practice. They were taken up and taken forward into practice. We were able to show, really for the first time, that a fully integrated point-of-care screen and treat approach worked and was scalable, acceptable, effective, cost-effective within a primary care setting. But I think what we really need to do now is move from we have one where Paulus is leading this program in Western Highlands. We have one province which is going to scale for elimination, both of the vaccination and the screening and the treatment, and we're gradually building on additional provinces. We have 6 other provinces that we're supporting that have gained their own funding. They've gained their own funding. Many of those are finding funding through the provincial health authorities. We've gained and supported them in finding funding from other philanthropic donors. And it feels very piecemeal. It needs to be much more coordinated. It needs to be much more cohesive. We need to come together and make this a reality for the whole country. And I think that is the challenge. And so in terms of, I'm not sure what we can necessarily share, but I can certainly share for all of us this tremendous desire to move forward, to try and really, really move from what is currently really the foundation of a national program to be a credible, sustained, long-term national program. And I think the opportunity that perhaps with the diagnostics, and going back to your point just now around COVID diagnostics, there are a lot of, particularly of the Gene Expert platform, there are a lot of instruments that are currently available in Papua New Guinea that were provided through for COVID. We could pivot. We could use those. They could be applied, readily applied, to support a national program. There is an awful lot that we could do, and I think they're really. I think, as Karen said earlier, we do have the tools. We are on the. I feel like we are on the cusp of being able to deliver this program, and so the future, I think, at this point, does feel very bright. probably for the first time for many of us have felt for at least 15 years.
Thank you very much. So the key, as we heard from both Jane and Andrew, is really that stakeholder engagement and the passion and commitment from both the patient community as well as the healthcare worker community. Lucas, I think Australia has played a significant role in supporting countries in the region. So what else is planned by DFAT and the Australian government in the international efforts to eliminate cervical cancer by 2030 among people living with or affected by HIV?
Thank you, and always great to answer these kind of questions. Thanks to Lady Ross, who's very good at keeping us accountable. So thank you. I just got to Meanjin in Brisbane, so I want to thank the Derwal and Jagera people for having us on their land as the rightful owners. And great to be part of this prestigious panel. I feel like an imposter with people like Jane and Ross and Meg here. But I think it's very clear, and we can talk quantum and size, but it's very clear that Australia is very committed to these. Australia has quite a long-term stake on HPV control, long-term, decades-long cervical screening program, and of course our involvement in the development of the HPV vaccine, the first national program. And now we've got decent coverage with 80% or 81% of girls, and I think 76.5% of boys having a full course of HPV vaccination, which is great. And we are cognizant that needs to change globally. We have been very vocal in Gavi in terms of incorporating the HPV program and expanding that, and there's been nearly 10 million girls vaccinated through Gavi-supported programs, including expanding to non-traditional Gavi-supported countries and some of the work that is happening in middle-income countries, and we will keep strengthening that approach. And of course, a lot of our investments across the Pacific and a lot of our partners here to support these programs. But ultimately, we recognize that as the Global Fund has been very clear with the health system and primary care strengthening approaches in the last now many years, is that, and we all know this, we need to move away from piecemeal vertical programs. And while it's as in the position as a donor, although that term is a bit, I'll move on. As a country that invests in development assistance, there's a tendency to support, and it's easier to explain those kind of vertical programs. We're very committed to, as Lady Rose was saying, trying to diagonalize those approaches and still being able to explain and tell a coherent story to our societies, for our ministers to explain on what we're doing in different diseases, but making sure that what we're doing is country-led, is complementing what's happening at the health system, and is actually strengthening that primary care interface that ultimately delivers to the priority populations that we're talking about, as opposed to the specific disease silo funding. And our approach for the health program in the next 5 years in the region through Partnership for a Healthy Region actually moves away from a very health security focused approach that we've had over the last 5 years. And we look at non-communicable diseases, although again that term is a bit old-fashioned, cross-cutting priorities, health system strengthening, and just what are the priorities for our partners in the Pacific, for our partners in Southeast Asia, and how do we help deliver on those priorities in a comprehensive manner. So we will have some program updates in the next few months when the outcomes of that Partnerships for a Healthy Region round comes out. The other thing that I wanted to say, and it's really important that alignment of the very strong advocacy from the HIV community now in this HPV interface, because what we're seeing nationally and internationally is quite a degree of pushback to a lot of the victories or the wins that we've had in the last few decades. WHO knows well that even in very technical documents, very technical subcommittees in the bowels of the international bureaucracy, even maintaining normative language that was agreed on gender inclusiveness in the inclusion of LGBTIQA plus people and on basic human rights things is now not a given. We are reaching a point in which in a lot of international declarations and statements, just maintaining language from 5 years ago is a win and not rolling back on that. So that's why it's very important that governments and countries like us, but civil society and international organizations maintain that really strong commitment that the only way we can address these things, whether it's HIV, HPV, the intersection of both, is by having the voices of the communities affected at the center, a human rights approach, and gender inclusive, disability inclusive, social inclusive, LGBTQIA plus inclusive, just human rights really, in all these things, which is no longer a given, unfortunately. But we are very committed to making sure that we don't roll back on that. Thank you.
Thank you for that, Lucas, and thank you. Yeah, thank you for highlighting the pushbacks from different areas, whether it's obstetricians and gynecologists or against the human rights in general. Lance, I must thank you for agreeing to step in for Cordelia Katubre from Ministry of Health Uganda, who was unable to join us at the last minute this afternoon. We heard from you earlier around the work, the important work that CHA and Unitate and others are doing in 14 countries. And we also heard repeatedly throughout the day that one of the barriers to scaling up is the cost of both vaccine as well as the HPV DNA test kits. What more do you think can be done? I mean, the HIV world has really been very good in a way, I guess, in terms of advocating for price reduction. I mean, we've got many examples of that, but how can we apply that knowledge and some of the frameworks, really, to push for this in HPV?
Okay, thank you very much. There's a saying which normally I've had, that if you want to go fast, you go alone. But if you want to go further, you have to go together with different people holding hands. And in line with that, I think integration is one of the key themes here in looking at HIV and integrating with other program areas, service program areas. And this is very, very evident in terms of how we've implemented and the lessons learned in terms of our implementation, looking at integration from the donor level, the national level, MOH, and even the subnational level. And I'm even happy to see that at the donor level, at the decision-making level, it's very, very integrated, because we've seen, even in Kenya, recently we had Global Fund calling for proposals, and this brought in every single player in the different health coming together and trying to leverage, to merge onto the HIV program in terms of just having some of the program areas supported through that. And this, in the long run, becomes inexpensive in terms of implementation, as opposed to different donors A, B, C, and D funding different streams, yet at the service provision level, the service provision is integrated. So that's number one. Number two, in terms of market shaping, CHA is very, very instrumental in that at the higher level. And this is just to work together with different manufacturers, assuring of volumes in terms of once they start implementing, and just in terms of price reduction of some of these consumables, some of these commodities, because with the scale of many people benefiting from that, yes, the cost per item can really go down. And in the long run, you find that the governments which are benefiting from this are able to churn out some money to be able to support some of their own initiatives. And number three is we have the private sector engagement. And here we've seen, post the work we've done back in Kenya, we've seen the MOH picking up some of the heavy lifting and directly engaging with different manufacturers, different suppliers, in terms of just having an MOU with them, having an agreement with them that if they let's say, for example, place a platform, they'll be able to buy commodities. If they do this, they'll be able to do that. And this just enables different countries be able to be self-reliant and self-sufficient. Number three is in terms of health financing. And I think this is something which is coming up slowly by slowly for African governments to include some of this intervention, some of this supporting these service areas in terms of being part of the national insurance programs. For example, in Kenya, we have the NHIF, and this is supposed to support both the screening and the treatment of screening, treatment, and even just provision of vaccines, and even other program areas to support from an internal financial bit. Then, last but not least, is supporting research, whether it's operational research, whether it's implementation research, feasibility studies in terms of just how best we can be able to use the limited resources in terms of using the limited resources to gain more, to be cost effective, to be very efficient in terms of achieving healthcare for all. Thank you.
Excellent. Thank you very much for that, Lance. And Meg, from a WHO viewpoint, what else would it take to commit to your elimination, well, not yours, WHO's and the world's elimination goal for HPV-related cancers by 2030, in the general population as well as for people living with HIV or affected?
Well, thank you very much. And I want to say I'm very pleased to have been here all day today, even though it's been it's a struggle with the time difference. But I have to say, every time I come to one of these events where I don't go usually, I learn something new. And us also having taken on the STI portfolio as well as the hepatitis portfolio, I'm starting to see so many connections and linkages that, you know, may not be evident to everyone, and that we have to make really overt and evident. The first thing I would have to say is, number one, our World Health Assembly, our resolution is around elimination of cervical cancer. Now, I think perhaps the first step is trying to think about how we can change that to HPV-related cancers. And that's something that, you know, with a member state who is very interested in sitting on the World Health Assembly could put that forward to say, are we limiting ourselves? And I know in the beginning this happened because it was the prices of vaccines were high. The modeling had a long-term horizon, but perhaps it's time to change that. And I would also have to thank Australia, who's been incredibly supportive of all the challenges against the pushbacks that we're seeing on language and ensuring that people are at the center. Secondly, I think we have to look at how do people understand virus versus long-term outcomes with a cancer. And we've seen this now with our hepatitis B and C, that the connection is very, very distant in people's mind, and the risk is very distant. So how do we change that and talk about the fact that for governments, you invest now, you will save in 20, 30 years so much more. And the investment case is an example that we probably need to have many more investment cases, not just for women and cervical cancer, but for boys and also for people living with HIV, for people at greatest risk within those groups, and ensuring that the investment cases are really clear at each level. And I think that will help us as we move forward. The other, I would say perhaps we have to lift up a bit of our ambition. When I heard the number of deaths and new infections, they're half of what the deaths of new infections are for HIV globally. So 700,000 new infections every year, 340 or 50 deaths per year, that's half. And yet for HIV, we are saying we want to make our 2030 goals and targets, which is 1.3 million new cases, 630 deaths. Yes, excuse me, yes. But yet we have Australia, who has done an excellent job of looking towards, and we'll be talking about, virtual elimination of HIV transmission over the next several days. So what is our ambition about the virtual elimination of cervical cancer, of HPV-related cancers, and making midterm and more perhaps aggressive and ambitious targets to help us get there, or work city by city, population by population to show that it can be done? So I would say, maybe with Australia's lead, maybe with PNG's lead, how do we increase our ambition and show that it can be done? I think the other thing that we've learned from HIV is optimization, meaning simplification. If we had 20 different regimens for antiretroviral therapy, we wouldn't be where we are today. And I think, we've simplified the screening, triage, and treating. But when I also present our guidelines, I say we have a lot of options, and each of those options has a cost, has some disconnect, meaning that people will apply that differently in different countries, and therefore you may not have as great of a reach. Could we simplify even more? Can we go from screen right to treat as opposed to screen to triage? What would it take to get there? So I guess that's a call to the researchers and to ourselves as how do we make this a real public health approach and see where we can have the same outcomes without having the same, perhaps, level of interventions up front to achieve those outcomes. So can triage be simplified? Can we have an HPV test that tells us immediately it's 16 or 18? Do we have whole genome sequencing that has been developed really quickly under COVID that can be connected to our testing? How are we connecting into, all of the new innovations around diagnostics, around testing, around genomes? I think pricing is clear. And the single-dose vaccination is clear, and that has to be taken forward. And perhaps it has to be written into the resolution that, look to the most cost-effective interventions. And lastly, I would really like to see that, that we look at that time horizon. I was just discussing, I don't want to complicate the modelers' lives, but on some way, what would it take if you moved up that time horizon for elimination to 20 years from now, for 10 years to now? What is it we need to do up front, as opposed to saying this is all we can do up front and it's going to take us 100 years? So I think in many ways, increasing the ambition, working that ambition into our next, into the next report that we have to report out at the World Health Assembly, perhaps changing the ambition of the World Health Assembly resolution, and then working with all partners. And I would have to say, lastly, people at the center, people who are advocates. We've learned this from MPOX. We learned this from all the work that we've done. Communities at the center can make a change much faster than researchers, public health officials, and people working in governments. So if there's a demand, I think there'll be a response. And I hope we could take that message, and perhaps you're going to have a readout at the larger meeting, because I think this is a really incredibly nice group. I had wished we had some of the advocates who are over at the hepatitis and HIV co-infection meeting here, because I think they could bring some of that energy to here. So what are the linkages with, say, virus and cancer outcomes? And maybe making that link stronger would help this group actually move a bit faster. So thank you.
Thank you, Meg. Andrew, I don't know how you feel, but I feel like we've achieved some of the things that we set out to do. We can get WHO to increase the ambition at World Health Assembly, and next year at the Munich conference, we'll invite the advocates to this meeting. Great. Now, my final question is to Lady Ross. We've heard of the commitment that the Global Fund has made to, funding various programs. From what you've heard, what are the barriers that to action that you see that will move the dial forward?
Yeah, it's terrific to have heard all the positive stories, but there are still very big barriers. Hard to follow, Meg, because I want to say ditto, ditto, ditto to everything that you said. But I think some of the things we've heard today are obvious. A, there's not enough money. Financing is an issue. Financing is an issue for the Global Fund. We don't have despite raising $15.7 billion, which was a fabulous achievement, fantastic achievement, billion US dollars, it's not enough. And that's to just continue funding what we've been doing before and adding a little bit more on. So somehow we have to, in the developed world, change the dialogue. developed countries do have to give more ODA, without question. Private sector needs to do more. But, I mean, I think one of the problems when I speak to the Australian government, and this isn't to Lucas because we haven't had that discussion yet, but he'll hear it many times from me. Yes, Australia is relatively generous as a donor, but when you ask for more money, the answer that always comes back is, number one, we have to have bilateral, or now multilateral, multi-partisan agreement to this. Not Labour, not Liberal, everyone needs to be on board. So how does Australia as a society put that pressure on politicians that we do need to do more? Frankly, we're not doing, I'm speaking to the Australians in the room, we're not doing nearly enough. Our aid has dropped to less than 0.1% of GNI, and that's just not acceptable. And if you look at other countries around the world that we should be comparing ourselves with, like Canada, they're so much more generous than Australia is. So people have to start agitating so that the government gets the message. Yes, yes, we're doing something, but we're not doing enough. The other thing that comes back always is, oh yes, we'd like to give more, for example, to multilateral, but we're doing so much in the region. Well, frankly, a lot of what's happening in the region, some of it's terrific, but some of it's not so terrific. I'm not speaking necessarily about the health budget here, but aid in general. And I think we have to stop thinking we've got to put our own sticker on everything and take credit for it and think much more about public goods and well-being of people. So for all the Australians here, please continue to agitate so that we can build this multi-partisan approach and acceptability of doing more. But given the constraint of financing, the issues of value for money, getting the most money, most for your buck, are really important. And that's where the integration of services is so important. Morko, wasn't it, who spoke very clearly about that earlier in the previous session. You know, we talk about it, but how? How are we going to do it? We have to focus on very practical questions, not at an international level, but in a country-specific, region-specific way. How can you do it? But we have to. There's not enough money, so we have to find the economies of scale that we can. Of course, there are lots of other clinical barriers, which we've heard about, but ultimately, it all takes money. The issue of bringing the price of diagnostics and treatment down, it's really important. It is a question of scale. We've learned so much from HIV. How can we apply that to other diseases and areas? We need to be much more ambitious, basically.
Thank you, thank you. We have 10 more minutes. If there is anyone from the audience who would like to either ask any questions or respond. Eric? Oh, sorry, Nitya. I was looking at this side of the room. Nitya.
Thank you very much, Adiba, and all the panelists. This is very impressive, for this meeting to be able to bring everyone together on these important panels. My question is about primary prevention and the role of the funder in doing that. Now that we have various prices of HPV vaccines in different countries or settings. And we know that Global Fund, PEPFAR, are the main funders for key populations, including key populations living with HIV. And I just think that it's just a tiny amount of money to be added to what we will say that this is comprehensive sexual health packages for key populations, but I haven't seen this being put as part of the funding request either from Global Fund or from PEPFAR. And what Meg mentioned about like integrating HIV, viral hepatitis, and STI all together. I mean, we don't very much talk about HPV as part of the STI in that global strategy or regional strategy. How can we do this? Can we say that HPV is the only STI that is preventable by vaccine, but we are not like using that to the level of the actual implementation. Thank you.
Thank you. Meg or Lady Ross?
Sure. All I can say is I agree. I mean, because absolutely, when I speak or when I think about hepatitis B or hepatitis C, I'm like, these are the viruses that we actually have a cure for C. We have a vaccine for B. There's no reason that we should be living with hepatocellular carcinoma that's associated with with the hepatitis viruses. I would say the same for cervical cancer, for cancers related to HPV. We do include HPV as part of our package of STIs, but this may be a division that has happened unnaturally or naturally over time, where if people are looking at priority from the end outcome of this, let's prevent cervical cancer, and how do we think about it from the NCD view, as opposed to, let's do the primary prevention, the vaccine up front. We'll never have to get here to the NCD component. I think it's about flipping the discussion, and we can do that more at our level and our headquarters. But I think it's something that then needs to be modeled, because I can see once we shift our language, sometimes that shifts language in a sort of downstream approach. So I'm completely with you about the small amount of money to go from the donors to this. I won't say that I would advocate that, yes, this would be very important, and I'm sure if a country wrote that into their Global Fund concept note or proposal, it might come through. But it's also, how do we engage in the other donors, whether it's Gavi, CEPI, others who are doing the primary vaccination? How do we unlock that and ensure that the vaccination can go to boys, can go to people living with HIV, men as well as women, at different age ranges, based upon the evidence, for sure, but a bit more ambitious than we are now. Thanks.
I just wanted to add the problem coming back to countries. While the Global Fund, particularly in this round, has given very clear guidelines on integration of these issues, I've seen some of the results of the proposals that came in Window 1, and there's not nearly as much as there should be. We haven't had an analysis of Window 2 yet. Window 3 is still to come. So how can we change the dialogue in countries? Because this is all reliant on what the countries are asking us for, what they want us to fund. But if they're not prioritizing it, how do we change that dialogue? I think it's all very well to do it at the peak body level, but we've got to get the dialogue changed in country.
Yeah, thank you, Adiba. Just to answer what Lady Rosin just said, I mean, during the national dialogue in Côte d'Ivoire or in Guinea, we invited the National Cancer Programme to be part of the discussion to prepare the funding request. And obviously, at the end, there are some budget lines dedicated to cervical cancer. No, what I wanted to mention is that you were right when you said that we need to raise more money, definitely. But we also have to send signals about the costs of some health products. I'm very happy to see that CFAID is supporting this meeting. But the price we are paying for the cartridge for HPV PCR, it's much more expensive than Abbott or Roche. There's something wrong here. And I'm not going to, I don't have the solution, but Meg, when you mentioned that maybe we should invite the HIV and hepatitis activists in the room. Maybe they could do something, because the price we are paying, the price the Global Fund is paying, after purchasing thousands and thousands of GeneXpert machines. And now we have to pay so much. That's not acceptable on a moral point of view, and it's strengthening the chance to offer more services for women in the countries where we are working. And once again, that was wonderful to have this pre-meeting. You cannot imagine how isolated we feel in some countries when we are working on cervical cancer. Thank you.
Andrew.
This has been a great panel, a very inspiring panel. And one thing that struck me in the words of Andrew, of Jane, of Luke's, all of you just about actually, was how much it reminded me of where we've been in HIV. We had minor activism and things happening here and there, and then it was really activism and it was the scale of the epidemic that enabled this to happen. But it was coordinated. There was loud and noisy activism. There were goals set that seemed. I will freely admit that the fast track goals initially seemed ridiculous to me, until we achieved them in many countries. Not all countries. There is still work to be done. But clearly, having incredibly ambitious goals is energising. And even if the majority of people say, these are ridiculous, we can't do that, to start with, having a vision that is really, really ambitious is where it needs to start, I think. So, Meg, I really agree with you on that. And inspiring panel. Thank you.
Okay, if there's no one else coming to the mic, it leaves me to thank everyone, to the panelists, the fantastic panelists, as well as all of you who've stayed for the rest of the afternoon, even though it's perfect out there, as the Queenslanders would say, perfect, what is it, sunny one day, perfect the next. So don't worry, there'll be many more perfect days for you to enjoy, although we've locked you in this room, this windowless room. But I think what we've learned this afternoon is we need to obviously involve the community. We need to infuse the advocacy and activism into pushing the HPV agenda forward. We need to be much more ambitious, and Meg is going to take this to the World Health Assembly in May. And Lady Ross is going to find us much more money from Australia, from France and Canada and all the high-income countries to help us in the lower middle-income countries. So thank you very much, everyone. And if you feel that this has been useful, Andrew and I and others in IAS, but especially Emma Williams, who's worked day and night to put this program together. And of course, our sponsors, Unitate, Cefit. I think there's Cefit people still in the room about the cost of the kits. And who else were our sponsors? CSL. We will hopefully be able to take this to Munich next year, where, inshallah, the audience will be bigger with the activism in the room. So thank you very much for being with us.